is shown to be very valid. And this can be used for babies 2 months old to 7 years. I think I would use it more on neonates. Do you use the black color?
Yeah, we generally use that on our basically I think it looks like cases.
And have you heard of this one, the CRY scale? And so this is just one more, and this is a neonatal pain assessment. And the nice thing about this is that it takes both things that you observe and physiological responses. So you can't, so you're basing this on more than just, oh, I see that the baby's moving their legs up, I see that they're crying. But sometimes when there's pain, the baby's O2 sats will decrease. And sometimes their heart rate may increase, the blood pressure may increase. But we are also looking at their facial expression and whether or not they're sleeping. This is kind of more of a long term because of the sleep piece. Because in an acute, giving a baby a shot, you probably wouldn't see a difference in their sleep pattern. So once again, it's cry, absent, high pitched, so it's a very loud cry. But with this one, it's a loud cry and they can be soothed. So mom picks them up and they stop crying, or you pick them up and you rub them and they stop crying. This one is, it's a high-pitched cry, but they just will not stop crying. It takes a lot to console them. The O2 sat, you want to make sure that their O2 sat remains above 95%. And so it's 0 points, it should be if it's on room air. And it's 1 point if, in order to maintain that 95% O2 sat, they require less than 30% oxygen. And it's 2 points if they require more than 30% oxygen. Heart rate and blood pressure, you would watch whether or not there were increases. These cries has also been shown to do well between nurses, and it's shown to be valid. So all of these scales have been researched well, and they're good things to be using in practice. So the other thing that I wanted to talk about first was, we talked about the other factors, was one article that I read about things that nurses tend to miss when they're missing pain. So the 4 things, this was an observational study of nurses in the hospital and with their post-surgical patients. Nurses' responses to interruptions of activities decrease their ability to observe their patient's pain. So I've got to do something else. I've got to take somebody's blood sugar, I've got to take their temperature, I've got to take their blood pressure. And so while they're doing those things, they don't notice that their patient is grimacing. They don't notice that their patient is moaning or moving, or even if their patient says, hi, I'm in a little bit of pain, they delay the amount of time that it took to get the ibuprofen or the Tylenol or the pain medication because they had other things to do. Nurses' attentiveness to cues of pain were not always in tune, so once again, those grimacing, even verbalizations, moaning when they were moving a patient, so moving a patient from bed to bed, they didn't always stop and think, well, it might be time for this person to have a pain medication, why don't I give them their pain medication before we move them? They were more oriented to the task, like, I need to get this done. Once again, I need to get this done, the patient needs to be moved, rather than the patient's in pain, why don't we see if we can do something about that before the next task. Nurses varying interpretations of pain, and this isn't whether or not, this isn't a scale of 1 to 10 or isn't judging whether or not their patient was in pain, it was the things that they thought caused pain. So nurses were aware that a patient would have post-surgical pain. If you have an incision, it might hurt around the incision, it might hurt inside, but they didn't think as much about Foley cath pain. So it might be, the area of the Foley catheter might be irritated, and so when patients complained of that, they didn't pay quite as much attention. They didn't pay quite as much attention when it was simple things like blood draws. And the last one is that nurses' attempts to address the demands of several factors. Nurses, doctors, other patients, those get in the way. So, Dr. So-and-so needs this right now, so I can't go assess my patient's pain. Or I need to report off, so I can't assess my patient's pain. They rang the bell, I went in, they said they were in pain, but I really couldn't spend the time because I had to give a report. And so these are just things for you to keep in mind when you go into practice, because pain is a really important issue, and we don't want our patients to be in more pain than they need to be. They're already often scared, away from home, they've had surgeries, they're fatigued. And if we can just pay attention to some of these simple things and make some simple changes, then we can make a difference in our patients' lives. So that's the pain part. Questions? Thoughts? I have a post-test too, and it has a little evaluation section at the bottom, so you can write that she talks way too fast, or she says too much, or what you liked and what you didn't like, and that sort of thing. I'm just going to pass that out to you really quickly.
Tell us if you know what a Foley cath is. Raise your hand if you know what a Foley cath is. Just a couple of you. So you might want to explain that.
So often people have problems urinating after surgery, and so a Foley cath is a catheter that you place through the patient's urethra to collect urine. It's often used after surgery. I had a patient who actually had to have it for a few days after surgery because she had a reaction to anesthesia and her bladder wasn't contracting the way that it needed to be, and it was filling and distended, but she couldn't release. And so they placed the catheter, which is, a skinny tube that goes directly into the bladder just to drain urine.
Collects in that bag. So it might be a one-time thing only where the catheter's put in, they drain it and take it out, or it might be, has a little balloon on the end of it and they leave it in for a long time.
Sometimes at work they do it so that they can get clean urine sample.
Because urine that comes from the bladder should be sterile unless there's an infection. So if you're getting it directly from the bladder, their anatomy is very close together, so you tend to have a lot more contamination from other sources.
And so that catheter you take out immediately. You get the sample and then take it out. You wouldn't leave it in to collect into a bag like this. So that's what your colleagues are doing this week and next, I think, or soon, in the afternoon lab. We'll teach you how to place a Foley catheter in a male or female patient, or to place any kind of urethral catheter.
There are also straight catheters which don't have a bag. The Foley catheter has a bag to collect the urine, but a straight catheter you might use a sterile container if you're just going to do it once.
Do you mind going back to your cartoon in the beginning?
No.
I just had a thought about it. We found out right here, but okay. So I was looking at this and I thought, tell us whether the questions here are is open question, closed question. This is an open. I'm just asking the class. Okay, so you've got the questions. What is it, boy? Want to go outside? Open question, closed question.
First is open.
First one's open. What is it, boy? You ask a question like that, you might get pretty close to what the problem is, right? Or what the interest is. What is it? What's going on? What is it? Are you hungry? Are you hungry? No. Want to go outside? No. That's closed, right? I think it just gives such a great example of the difference between an open question and a closed question, and how you're going to get to the information that you want better here with an open question than a closed question.
The other thing that I forgot to mention that I wanted to talk to you about open questions is, and you have a list in your book when you read the chapter, and there's a few more things in there of do's and don'ts. One of the things that I was always told for an open question, why sounds like such a great open question, but it's not. Why often sounds like you're demanding something of somebody, like you're demanding that they justify what they did or how it feels. So, first I went outside. Why? You don't mean to be judgmental, you're really just trying to explore, but it comes off sounding like you want to judge what their intentions or what they're doing.
So you're going to be reading about that for next week in Jarvis, and just think about how it makes you feel. For example, if you stay out late at night and you come in and your parents say, "Why did you do that?" It's a whole lot different than saying, "Tell me about last night," right? And the way you respond to it.
Let me just pass these guys out. So these are the same exact questions. Hopefully.
So Rachel really used good evidence-based practice here, didn't she? I think you've heard about evidence